So welcome back to our second webinar on the Novacare Maple device as distributed in the UK by Pioneer Medical Europe. In this webinar, we are going to be looking at how to use the EMG, so the electromyographic functions of the Maple device. We need to remember what we are measuring when we are looking at EMG. We are looking at myoelectrical activity, so it's neuromuscular function. We are also looking at motor nerve activity, mainly of the pudendal nerve, but also branches of the S3 and S4 sacral motor nerve roots. We are not looking at range of movement. We are not assessing strength, and we are not assessing pressure. We all have our physiotherapy toolbox that we can use, such as digital examinations and other tools such as dynamometry, pressure biofeedback, all of these other tools that can find more information about range of movement, strength and pressure. It does seem to go hand in hand that if there is increasing myoelectrical activity within the muscle structures, that movement, strength and pressure will also increase and improve. And in cases where there is too much electrical activity, especially at rest or when trying to release, then as this reduces and normalizes, then the movement, strength and pressure will also improve. But we are not measuring this when we are looking at the information from the Maple device. So we do get a line graph which looks at the electrical activity within the muscles that we are testing. Now with Maple we can test all 24 electrodes, so all the areas where the electrodes will sit within the vagina or within the rectum, or we can filter out and look at individual areas up to 2 electrodes or down to 2 electrodes at a time. So we can be as general or as specific as we want. There are 3 protocols for assessment that are very strict. We need to keep to these. The first one is the resting assessment. So at rest, the patient doesn't talk or move, ideally. If the patient sneezes or has to move on the bed because of discomfort, then the assessment can be stopped and restarted when they're more comfortable, or after having had a glass of water if they have got a tickle in their throat, for example. Each resting assessment should take 60 seconds, and ideally no talking from therapist or patient, no movement from the patient. The therapist can say at 30 seconds that the patient is halfway through. The next assessment is maximum voluntary contraction, MVC. So here we're looking at the muscle's ability to perform fast fibre activation and also fast release. And here we have 3-second squeezes, repeating 10 times with 3 seconds of rest in between each one. So it's 3-second squeeze, 3-second release. Now the squeeze doesn't have to last for 3 seconds, but there is a window of 3 seconds. And fast fibre activation will happen between 0 and 3 seconds, but after 3 seconds there will be an inclusion of slow fibres, so we limit it to the 3-second activation. And we do limit the rest to 3 seconds. If you do an EMG biofeedback, obviously you can increase that rest period for training purposes, but when we're looking at assessment, you want to be keeping that rest period to 3 seconds. The final assessment is endurance. There we're looking at the slow fibre muscle capability. And here we have 3 repetitions of a 30-second squeeze. That does seem like a long time, but you can see quite a lot from both the patient and from the muscles when completing these 30-second squeezes. After each 30-second squeeze, there is a 60-second rest. So those are the protocols for assessment, and those assessment findings are saved in both grid and line graph format on the iPad under the patient's details. There's also a training area within the EMG function of the Maple. That's not recorded unless you specifically record the screen during the treatment, but you can have a little bit more freedom there because it's then not saved to the client's file. So if the probe is inserted vaginally, the normal values at rest are between 0 and 2 microvolts. If their resting activity, electrical activity, is greater than 2, then have a look at their MVC findings. And if their resting activity is on or below 10% of their maximum possible contraction, then that is still within normal ranges. But the majority of people will find that a normal resting activity is between 0 and 2 microvolts. The closer to 0, the more likely it is that that muscle is less active and may find it difficult to find activation in MVC and endurance. Anally, the figures change slightly and they increase, as you can see in the red line compared to the green line in the image. It goes from 0 to 4 microvolts, or again 10% of maximum contraction. Now we do the resting assessment first, so you may not know initially if there is a 10% of maximum contraction, but you can always review that and go back to the patient file after having done the MVC and endurance tests as well. There is an onset and offset measurement. The onset is from the blue circle to the red circle, so from the lowest point in the EMG line graph to the highest point when squeezing. So that is the time taken from absolute rest to absolute maximum contraction. And it should be within 1 second if the fast fibres are working within their normal functional capacity. The offset then is the time taken from the maximum contraction, the red circle, down to absolute rest, which is the lowest point and the green circle on the image. So you can see here again that should be within 1 second. The slower that is, the more challenging those muscles are finding it to let go and relax in between squeezes. So you may have an element of muscle overactivity or hyperexcitability in that area. We have 2 visual scales for the grid. So the first scale is the grey scale, and that is the absolute measurement for that patient. The 0 point is given by the reference electrode, which will be on a bony point of the patient. Any electrical activity that is found within any of the muscles that are being measured will show in the grey scale. The darker the shading on the grid, the more active the muscle, and that will be shown up both at rest and during activation, whether that's fast fibre activation or slow fibre activation. The blue and red scale is less important on a day-to-day treatment and assessment basis. The 0 point there relates to the average findings for the research that has gone on from volunteers with similar findings in terms of symptoms. So the 0 point would be the average, and then anything into the pink and red would show that your patient has more activity than the average, and anything in the pale blue to dark blue will show a minus figure, which is less than the average of those tested. This can be useful to see how your patient is doing pre-surgery, and if they are in the white to pink zone, then they are looking good in terms of how their muscles are working compared to others of similar symptom profiles. If they are in the blue, then it may be that they need more rehabilitation, or should I say prehabilitation, prior to surgery. But we can discuss this in the Maple training days. So we've just gone through this. So these are the scales of myoelectrical activity. The grey scale is what we would use more often than not. The blue and red scale we would use as a reference measurement, usually prior to surgical intervention, if that is on the cards. So here we have the grid. So we've talked about the development of the grid in the last webinar. In this webinar now, we're just going to go into a little bit more depth to remind you of how to interpret the grid. So we have sides or segments. Each side contains 6 electrodes. So you have 6 electrodes in the anterior side or plate. We have 6 electrodes in the left, 6 electrodes in the right, and 6 electrodes in the posterior. And then each plate will have a ring, and the rings will span all 4 plates. So ring 1 is the smallest ring and the deepest part of your electrode. And as the numbers increase, you are moving towards the outer points of the vagina or the rectum. So when you get to ring 6, you are at the vaginal entrance or the rectal entrance. So the larger the number, the larger the ring. The smaller the number, the smaller the ring. The smaller the number and the smaller the ring, the deeper the probe. The larger the number, the larger the ring, the more external the probe, or the more superficial the probe. You can press the centre of the grid, so the very centre point will have R and L written in there. And you can flip the right and left. You can't flip front and back, but you can flip right and left, depending on whether you prefer therapist view, which would be left on the right on the left, or patient view, which would be right on the right, left on the left. So that is completely up to you, and also depends on whether you are trying to show anything to the patient. So you want to make sure that it is as clear as possible, and you want to make sure that you've communicated what they're looking at as clearly as possible. So here we have the validated findings for the MAPLE grid. So we have muscle groups and layers, and this is vaginal insertion of the MAPLE probe. So the top left picture, you can see dark blue shading of the rings 5 and 6 to the right and the left. And here we have validated positioning of the electrodes for bulbospongiosis and ischiocavernosus muscles of the superficial pelvic floor. In the bottom left, we have rings 3 and 4 to the right and to the left, shaded in a dark blue. This relates to puborectalis. In the middle, at the base, we have dark blue shading for rings 1 and 2 to the right and to the left. This relates to the coccygeus fibres of pubococcygeus and iliococcygeus muscles. So you'll have coccygeus, the coccygeus fibres of pubococcygeus, and also iliococcygeus muscles in those areas. You can see from the top right and bottom right areas, pictures, that there is a lighter blue shading for the anterior and posterior plates with vaginal insertion of the probe. Here, there are muscles in the urogenital diaphragm region, but we cannot be absolutely certain as to what we are getting feedback from, and the same posteriorly with the anal canal. So we may get some feedback from the external sphincter as an example. So you can see here that the anterior and posterior plates will give you feedback, but you cannot be absolutely certain as to which muscles are specifically providing that feedback. With anal insertion of the probe, the outer ring 6 relates to the external anal sphincter. This is with rectal or anal insertion of the probe. So that's the top left image. The bottom left image, you can now see rings 3 and 4 in the posterior right and left plates relate to the puborectalis muscle. And the bottom right image, rings 1 and 2 for right, left and posterior, will relate to the pubococcygeus fibres, again, the coccygeus fibres of pubococcygeus, iliococcygeus and the coccygeus muscle, or ischiococcygeus as some people will name it. You can see that the anterior plate, again, we cannot be absolutely certain as to which muscles are providing the feedback for that plate from rings 1 to 5 due to the presence of the urogenital diaphragm and vagina. You can also see that ring 5 has not been coloured at all, and that relates to the potential overlap between puborectalis and the external anal sphincter. The internal anal sphincter will not show up on EMG biofeedback as it is a smooth muscle and will not produce the electrical activity that will show up on the EMG findings. So when we are using the Maple EMG function, you will get information from the line graph, you will get information from the grid, and you will be able to see a relationship between the resting assessment, the maximum voluntary contraction assessment, and the endurance. You need to look at all three of those. Now, with the grid, you can look at the whole grid in one go, or you can filter out rings or electrodes. You can go down to as low as 2 electrodes. So you can have a good look at the summary of the pelvic floor, and if you see, for instance, overactivity of puborectalis in rings 3 and 4 to the right and left, you could filter rings 3 and 4 to the right and left and see what the difference is. And with the filtering function and with the combination of both the line graph and the grid and the findings from rest, MVC and endurance, you can be super specific on your diagnosis and treatment plan. You also need to think about how your findings with the line graph, the grid and the assessments, how they link to observations and the symptoms of the patient. So you should have already done a digital vaginal or rectal examination, depending on what's needed. You may well have done other physiotherapy assessments of the rest of the core, the diaphragm, posture, range of movement of the spine or the pelvis. There's lots of things that you can link Maple into to find a complete and specific diagnosis and treatment plan. And you want to work on a specific muscle dysfunction. So what do you want to improve, and what are you going to focus on in your first line of treatment with Maple or with other physiotherapeutic techniques? Here are the measurement protocols. These will be found in the Maple handbook, which you will receive on purchasing your Maple device. And here are the biofeedback guidelines. So what to do in terms of underactivity, overactivity, what's happening with the contractions, what's happening with the breathing, and what's happening in terms of changing the EMG settings if necessary. But we can talk about all of this in the Maple Basic Training Day. Okay, so that's the end of webinar number 2. Thank you for listening. In the next section, we won't be going through practical, so that's everything there, but we will be going through how the Maple is set up.